Friends, welcome to my workplace at Ranaghat, West Bengal, India. Let us observe this surgery. This is a cataract with zonular dehiscence from 2 o'clock to 4 o'clock, almost 2 clock hours of zonular dehiscence. The patient is young, about 35 years old, a lady, had trauma, had developed cataract, and we have taken up this case for surgery. The main incision has been made at 11 o'clock and the side port at 1 o'clock, and now capsulorhexis. While doing capsulorhexis, we have to keep in mind that we have to keep enough rim width at the side of the dehiscence. So, the rhexis should look eccentric, as if you are going more peripherally where the zonule is attached, and you are almost at the center or little beyond center at the site of the zonular dehiscence. I did viscodissection of the capsule, and now this is a capsular tension ring. I didn't do hydrodissection because hydrodissection obscures visibility and it can hydrate the vitreous. Antechamber can be shallow and placing the CTR may be difficult. So, I did viscodissection of the capsule, and now here goes the CTR. We have to be sure that the leading end is going under the rhexis margin, under the anterior capsular rim. Once you are sure, we gently push the CTR and come to the trailing end. And now the trailing end must go into the equator of the capsular bag, but see what happened in this case. As I try to place the CTR, suddenly it slipped and it didn't go into the capsular bag. So, I am trying to pull the CTR, and with 2-3 manipulations I could bring it, and now I place the Sinskey hook in the eyelet of the trailing end, push it in the bag, and see the other end is also coming near, and then I release the CTR with the help of another hook. There is a small gap between the two ends. So, these two ends should not be in the area of zonular dehiscence. It should be in the attached area. And now I am pre-chopping this nucleus. This is a soft cataract. It's difficult to hold soft cataracts. So, we can easily pre-chop the soft cataracts with these two instruments. The instrument that supports the nucleus at the equator is called nucleus sustainer. It goes through side port, and the dominant hand goes through the main port, and two instruments can divide the nucleus into two heminuclei. Hydrodissection is done. I am trying to prolapse on heminucleus out of the capsular bag, and then I go into the anterior chamber. At this time the vacuum is 400, flow rate is 40, and ultrasonic energy is only 40% or 50%. Since this is a soft cataract, lot of ultrasonic energy is not required, just need little bit of ultrasonic energy. And then with the handpiece itself, I am trying to remove some cortical matter, epinucleus and some amount of cortex. But see, once the CTR is there in the bag, it is very difficult to remove the cortex. Even by this handpiece, we are not able to remove this, and we should not try hard. We should just take a Sinskey hook or a bimanual IA and don't pull it towards the center, just move it side to side, release it from the CTR and then aspirate. So, we have to give some quality time for this, we have to be gentle. This surgery is edited and it is in fast forward mode. So, you may think that I am not giving proper time for cleaning, but it is, I did it very slowly, and the cortex is nicely removed, the posterior capsule is nicely polished. Now, while filling up the capsular bag and the anterior chamber, I observed one thing. I injected lot of visco, but the eyeball was not becoming firm. So, probably a lot of viscoelastic substance, particularly HPMC, goes through the dehiscence posteriorly and the eyeball does not become firm easily. I enlarged the main wound a bit, which has not been shown here, and lens, monofocal intraocular lens single piece goes into the capsular bag. Another option is place a multipiece lens in the sulcus and do optic capture. But since this is a traumatic cataract, the rest of the zonule is healthy and strong. So, a single piece monofocal lens is not contraindicated in traumatic cataracts. You can place a single piece lens in the bag in case of traumatic cataracts. If the zonular dehiscence is only 2 clock hours or 3 clock hours, you need not put a segment, but if it is more than 3 clock hours, probably you need a segment. That is left to your judgment. Now, this is removal of the viscoelastic substance. We have to be very careful at this time. There is a zonular dehiscence and we should not pull any vitreous stent while we remove the viscoelastic substance. And I had some doubt that probably there is some vitreous stent. So, I took help of triamcinolone acetate and I find that there is some vitreous stents peeping through the zonular dehiscence into the anterior chamber. So, we must not pull these vitreous stents. What we do is we flush it out and take vitreous cutter. I can manage through main wound, but I recommend that you make a side port and do this through the side port. The cutter, what I do is I lift the main wound, lift the anterior lip of the main wound and leakage becomes less, and thus I maintain the anterior chamber. But yes, you can make a side port at 8 o'clock and use the 2 instruments through the side port, that is recommended. So, do a nice shaving of the vitreous stent so that there should not be anything left. It is done, almost done, and we have to check it again, injecting some more viscoelastic, some more triamcinolone acetate. At this time, I put an air bubble and put a little bit of triamcinolone acetate, because if we put lot of it, it can go into the vitreous cavity, and if the patient is a steroid responder, we will have a very tough time in controlling intraocular pressure. Yes, we find that there is no more vitreous stents in the anterior chamber. At this time, I am checking if the eyeball becomes firm and whether we need any suture or not, and find that the eyeball is becoming firm, no leakage from the main wound. So, I don't need a suture, but for beginners I would suggest that in such cases it is always better to suture the wound, because you may not have that ability to judge whether this wound will leak or not. Okay. I close the side port by corneal stromal hydration, and this is a final lavage and formation of the anterior chamber. The anterior chamber is formed nicely and the case is concluded. These are the post-op pictures after 7 days. Cornea is clear, anterior chamber is quiet, vision is 6/12 unaided. Patient is very happy. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon, serve your patients with love, respect, compassion, and great surgical competence. Don't wish it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom.